favorite person from South Carolina, except for you, Deb. And he has been here since the beginning and will help and do whatever needs to be done. He is a wealth of information and resource, and I'm really so proud to introduce Dr. Curtis Rogers.
I'm going to bring my list of questions with me. Before I start my little talk, can I have my Coke Zero? Somebody asked about size. We're in Texas. Everything's bigger in Texas. Size matters, except for the sodas. That's $2.50 right there. Size doesn't matter when it comes to some things, I guess. So, somebody asked about an alternative to SHANK3 at Synapse. So if you're deficient in SHANK3, is there another protein that can take that place? SHANK3 is integral to the stability of the synapse. It is a protein that functions as, you can think of as a stabilizer for the shape and the stability, structural integrity of the synapse, okay? So if SHANK3 is only present in half the amount that it should be, your synapses are not going to be as stable as they should be. They may not transmit the information from one cell to the other as well. So right now we don't have a way to replace SHANK3, at least right now, but the idea, and if you come to the research part, they will talk about ways to make those existing synapses function more efficiently. Is the best way I can say it. So if you think about all of us as we get older, you think about grandma losing her memory and having dementia or Alzheimer's, she is losing synaptic function. She's losing connections or memories. And we all do that as we get older, because things, as we get older, start not working quite as well. So that's what happens. If you're already at a structural disadvantage in your synapses, and we'll talk about regression, you'll hear that term used in Phelan-McDermid syndrome. If you're already kind of sitting on the fence with your structural integrity, as you get older, and it doesn't have to be much older sometimes, you start losing synapses. And I'm not trying to rain on anybody's party or predict, because some kids don't and some adults don't get regression that way, but some do. And we don't understand why some do and some don't. But right now, the goal is to try to get the synapses to be more efficient, because that might not be pertinent only to Phelan-McDermid syndrome. That may be important for autism in general, or Alzheimer's disease, or intellectual disability, a lot of different disorders that are caused by synaptic dysfunction, okay? When you look at genes that cause intellectual disability or autism, many of those genes code for proteins that are active at the synapse and are involved in synaptic structure or function, okay? NF2, somebody was asking about that in the ring chromosome. I think you got to remember that NF2 isn't classified as an autosomal dominant disorder, meaning that you only have to, this is going to get confusing, meaning that you only have to knock out one copy of the gene to have an increased risk of having neurofibromatosis type 2. We've knocked out one copy of the gene because it's deleted, okay? That is not causing NF2, though. What has to happen is NF2 is also a dominant but a mosaic condition. And the mosaicism occurs at the cell level, a somatic mosaicism, where all the time as we're sitting here, we're having mutations or variants occur in our genes. Hate to tell you that, but nobody's perfect because we're all changing as we sit here. The idea is that your molecular machinery, your gene machinery, will correct those mistakes. When it doesn't correct the mistake in that second copy of NF2, we've knocked out both copies. NF2 is a tumor suppressor gene. And if you think of those, because NF2 is a, quote, tumor syndrome, think of tumor suppressor genes as the brakes in a car. We also have genes that are called oncogenes that are like the gas in the car. And we've got mismatch repair genes that are the mechanics that fix those mistakes that occur. Changes in any of those genes may lead to a tumor syndrome like NF2 or breast cancer or colon cancer or whatever. So the problem is, if you've already lost one copy, you are at much higher risk for a second change happening that's going to cause disease. So you've knocked out both copies. That's why we recommend screening those individuals with a ring, not because they're all going to get NF2, because they're not. They're certainly not. But a higher percentage will than in the general population, so we know that, forewarned, we're going to screen for that because we want to catch that early, okay? Did that clear things up a little bit? I might have made it muddier. We'll talk about size in a second. So then Katie threw the clinical geneticist under the bus with the whole exome sequencing question. So, as a clinical geneticist, I see a lot of children with intellectual disability, autism. Some of them may or may not have additional physical features that may suggest a specific diagnosis. We try to fit the testing to the child and what we think is the most likely and logical way to sequentially order those tests. Because let me tell you, if you've had to go through insurance companies, they're not real helpful when you start ordering tests. We have to write these letters of medical necessity and things, and even when they say, oh yeah, go ahead and do that test, that doesn't mean they're going to pay for that test. And you may get a bill for that test. So we try to be financially responsible and at the same time try to be intellectually curious. If we have a child who's had a normal chromosome studies and a normal microarray, and they don't have any atypical physical features, and they are making progress in their development over the next year, then we may not order whole exome sequencing. More and more, however, especially for certain disorders like autism or unexplained significant intellectual disability, we're going to order whole exome sequencing. So it is somewhat dependent on where the clinical geneticist is trained. It may be dependent on how old they are and how comfortable they are with this newfangled technology called whole exome sequencing. I think the other thing to remember is that whole exome sequencing, while it may find something, it can open up a real can of worms too, because we can find a lot of variants of uncertain significance, or VUSs, and then we're at a loss to try to explain those. 5 years down the road, if you reanalyze that data from the whole exome sequencing, what you may find is what you said was unexplained is now either classified as pathogenic or disease-causing, or it may be classified as benign at that point because it's been seen in the general population without any problems, and so we say, okay, that variant's been seen before. There are, however, now, and Dr. Bettencourt is the expert on this, recurrent pathogenic variants in the SHANK3 gene. So there are apparently some areas where within that gene there's a higher risk for the variant or mutation to occur there because of the structure of the gene. The way the base pairs or the spelling of the gene goes. And one of those is multiple G's. Remember, your genetic alphabet's only got 4 letters, A, T, C, and G. But if there are multiple G's in a row, those tend to slip and slide a little bit, so you can get a recurrent variant that has either a duplicated G or a missing G in that area. And when that happens, you change the reading frame of the gene, because genes are read in triplicates. So a codon is 3 base pairs. So you read it, you read 3, 3, 3, 3, 3. If I throw an extra base pair in there, from that point forward, I've changed the letters that are being read in those triplicates. And pretty soon what happens is when you change that reading frame, you get to what we call a stop codon, which means that that's the signal for that gene to say, oh, I'm done. I'm through making this protein. Well, if the protein's supposed to be this long, and you get to a premature stop codon or termination codon, you may wind up with a protein that's this long. That protein is not going to have adequate function to, if we're talking about SHANK3, to provide that synaptic stability that you want. So that's kind of the explanation there, okay? Anybody got any questions about that? I know that can get a little hairy. And I'm not the molecular geneticist. You should hear them talk. I put this little subtitle here because you guys are the experts. You're already going through this. You know things, and as a pediatrician too, I don't want you to feel like your pediatrician, your family practitioner is a total idiot. They're not. They've never seen another child with Phelan-McDermid syndrome. What you want, though, is one that will learn and try to get to know your child and what this means for your child. But that will be the only child, likely, that they will ever see in their life. Your child may be the only child in their 5-person pediatric practice that ever has Phelan-McDermid syndrome, okay? You will need to educate them, and you need to be rather bold about educating them. So give them articles to read. It's okay when you go back the next time to quiz them on those. They can't answer your questions, and you say, well, maybe I need to change. Okay, so genetics is complicated. Katie's already given you a lot of this stuff. If genetics was easy, Einstein would have been a geneticist rather than a physicist, but he chose physics because he picked something easier. I don't have any financial conflicts. Like many of you, I feel the same way, overworked and underpaid. That's why we don't have enough geneticists. People were saying, well, my gosh, I'm having to wait 2 years to get in to talk to the geneticist. That's why. Because medical students have $250,000 worth of debt, and they don't want to go into a low-paying specialty like genetics. But, you know, that's just life. So everybody who you meet who is a clinical geneticist, I like to say they are there, they have a calling. And if any of you needs a personal physician and has a lot of money, I am available, okay? So here's Dr. Phelan, if I can get. She loves to dress up, I'm telling you. No, she loves to dress up. And here's Dr. McDermid. We see her every now and then. She comes out every now and then. So let me see if these will work. So all of these and some of these children are here. They're much older than these pictures. But if you look in here, what you'll see is, well, some look the same, some don't. Some share some features, some don't. It's not an easy diagnosis to make clinically. So again, don't throw the pediatrician or the geneticist under the bus, because it is not easy. I can tell you, I personally have had somebody come in and I've missed that diagnosis because it's just not that easy to do. We'll talk about these things right quick. Trying to figure out a number. It's funny, the shuttle driver from the airport asked me yesterday, he said, he said, are you here for that Phelan McDermott conference? I said, yeah. He said, well, how common is it anyway? And what does it cause? I was amazed that the guy really wanted to know. That's a hard thing to figure out. I can tell him what it causes, but the exact number we have to kind of try to back into. Because if you look at this right here, 1% of individuals with autism spectrum disorder had a disruption of SHANK3, or that gene. Let me tell you, you've hit a hot gene if you get 1% of individuals with autism have a change in that gene. That's a hot gene, because there's so many genes that affect that. Then, if you look at this one, 1.4% of individuals with ASD had an abnormality of SHANK3, so we're still about that 1%. And then, depending on what number you want to use there, because that changes, and if 1 in 100 individuals get that, so we're coming up to 1 in 10,000 to 1 in 20,000, okay? That is why your pediatrician is not going to see anybody else except your child with Phelan-McDermott syndrome, okay? So let's get to the features. And you guys know these features better than anybody. Hypotonia as infants, poor feeding, floppy babies, sometimes having problems with temperature control. That hypotonia thing leads to a lot of different problems. Developmentally, for muscular issues, sitting, walking, those types of things. It also leads to constipation. How many of your kids have constipation? Okay, a fair number. Remember what you do when you have a bowel movement. You can get it together and you can selectively push down and increase your abdominal pressure, which helps the muscles in your bowel expel the stool. The other thing you have going through for you is that your bowel does not have hypotonia. So if the bowel has hypotonia, those peristaltic waves, that constant pushing of stool through the bowel, doesn't occur as well. So we've got that going against us, plus the fact of trying to get it together to tighten just those abdominal muscles. Think about a little baby. When a little baby has a stool, their abdomen isn't the only thing that gets hard. Lord knows they look like their eyeballs are going to pop out of their head. Their fists are clenched. As they get older, though, and they develop, what they can figure out to do is to focus that energy. So that's a problem. So many folks, because of hypotonia, whether it's Phelan-McDermott syndrome or Down syndrome or Prader-Willi syndrome, they're going to have constipation. So they're going to need Miralax. An easy thing to do is to try to get more fluids in them, because that fluid that goes in the bowel through the mouth is going to stay there for a period of time and hopefully help soften the stools up. Softer the stool, the easier it is to get out, okay? The developmental delay issues, and nobody can predict what your child's developmental quotient or IQ is going to be, and it can't be predicted based on solely looking at the deletion size, because every child is different. And we just have to try to provide that child with all the advantages of therapies we can and see where they go. We need to try to maximize their potential by offering them that assistance. The speech is part of that developmental delay. You're going to see children here who will say many words, and you're going to see some children who've never had one word of speech. That brings up the importance of augmentative communication and trying to find a way for your child to communicate. And again, it doesn't matter whether we're talking about Phelan-McDermid syndrome, communication is the key, because any child who can't communicate is going to become frustrated. The parents become frustrated because, well, what's he thinking? What's she thinking? Imagine yourself being bottled up and you're trying to get your point across and you have no way to express that. So we need to try to find a way, whatever it is, pointing at pictures, using a computer, whatever, to try sign language, whatever, to let a child communicate. There is no evidence whatsoever that using augmentative communication will keep your child from learning to talk. If your child's going to be able to talk, this probably will augment that process and enhance that process of speech development, okay, because they can communicate. So don't let that scare you away. I hear that from parents sometimes. Well, if I teach my child sign language, they'll never talk. That's not true, okay? Normal to accelerated growth, I think we went overboard with the accelerated growth thing. Most of the kids have typical growth that is appropriate for the size of their parents, so it's consistent with the family. Large fleshy hands is true. How many of you have had problems finding shoes to fit your child? Yeah, because of the thickness of the feet, sometimes that's difficult to find the right size shoe that will fit. These, and same in the hands, it's just one of the little things we can look at that gives us a clue. Dysplastic toenails, how many children have flaky or brittle toenails? Yeah. That is a great feature for us to look for, but it is certainly not present in every child. So it's not going to make the diagnosis for you. There are other problems with skin and nails that can occur in other conditions. Long, beautiful eyelashes. Your child probably has eyelashes that a fashion model would kill for. And it is true, just incredible eyelashes. That's why they're beautiful children. I mean, all children are beautiful, but let's face it, your kids have eyes that are unbelievable. So, decreased sensitivity to pain, I don't think that's occurring at the skin level. So I don't think the problem's here. I think it's in the perception of the pain. We see that all the time in kids who have intellectual disability, is that the message is a little bit garbled in the brain as to whether this hurts or not. So you need to be especially careful, because your child might not learn as quickly or jerk their hand away as quickly if they put it on something hot. It's taking a little bit longer to process that, okay? How many of your kids have excessive chewing behaviors? Yeah. First patient that Katie and I saw, that was one of the main complaints that the mom had over the years, was that he was chewing on everything. And she joked, she said he'd chew the leg off the table if I didn't watch him. But that's how bad the chewing behaviors were. And they've got, I'll call industrial strength chew toys now that are available. And I think I think the chewing is due to frustration from lack of communication. and other issues that are going on, and it is a way to relieve stress. That's my thoughts about that. Autistic or autism or autistic-like behaviors, if you can't communicate, remember when they start scoring autism that communication is one of the big three on the autism rating scales. And so for a child who is nonverbal, they are going to have a very difficult time not saying that they have autism. Don't be afraid if somebody says your child has autism, because if it gets you services, and a child being autistic gets you services, it gets the school district money, which gets you services, go for it. Now we have parents come in and say, isn't my child autistic? That never happened 35 years ago when I was a pediatric resident. But now they realize, you guys are very bright, you realize, hey, if I have that diagnosis, I can get more services for my child, and that's what it's all about. These other features, dolichocephaly means a long, thin head. Sometimes we will have a bigger head, but a large head size occurs more commonly in kids with autism than in children who don't have autism. So there's some connection there, we think. Bigger ears, full brow puffiness around the eyes a little bit or on the cheeks. Deep set eyes because of the puffiness. Sometimes you can have ptosis or droopy eyelids. The nasal bridge is typically a little bit wider right here under where my glasses are, and the nasal tip here will be a little bit broader. So again, if you look around at all the kids that are here, you'll see some common features. But I don't think for most people enough to say, oh, this child has Phelan-McDermid syndrome. The other thing is decreased perspiration with a tendency to overheat. Perspiring, or where I'm from in the South, sweating, is a way to cool your body. It's your body's way, it's your radiator system, so that when you sweat, that perspiration evaporates and that cools your body. If you can't perspire enough, then you're going to more easily have an elevated body temperature, core temperature, and get overheated that way, which causes problems. So you just need to be aware of that and address that. Spend less time out in hot areas, like we're here for Record Heat. This was a great place to have the conference with Record Heat, wasn't it? We should have gone to Alaska maybe, but you just keep that in mind. You make sure your child is well hydrated. They had some vests over there that were cooling vests that you could put these little packets in to cool your child. You know, if you go to some place like Disney World in Orlando, Florida, your child may need to have something like that. You may need to plan your activities so that you're not out walking around in that hot sun. Maybe you need to go in January rather than July to go to Disney World. Sometimes there will be renal problems like reflux in the kidneys. We would advise for every child who's been diagnosed to have a baseline cranial MRI. And I know if your child is small, that's going to require sedation. And at the same time, they could do a renal ultrasound to make sure that there's no problem with the kidneys. Those are kind of baseline studies to do. And most of the times, we're not going to find anything wrong at that point. But even that is a good thing to know, because we know where we were, and if problems start occurring and we get a second study done and there's a change, then we've got that in our bag to help us know what to do. The other one there would be seizures. And the children who have and adults with PMS are an increased risk for seizures over the general population. But the majority do not have seizure. But Seizures are difficult to diagnose too because they can occur in many forms. So if you notice something unusual, and I think all of you should have a neurologist. Every person with Phelan-McDermid syndrome should have a neurologist, again, as their baseline. And if you notice any changes, think about the possibility that there might be a seizure. And they may have to admit your child to the hospital and do a 24 to 48 hour EEG or brainwave test to detect that. So the diagnostic criteria, Katie would tell you there are no set diagnostic criteria, so that's why we're kind of wide open. Does it have to include SHANK3? Does it not? That depends on who you talk to. We certainly can't ignore all of those genes that are proximal to SHANK3 because SHANK3 is right down at the bottom of 22. And those deletions may encompass, if they're large enough, may encompass 100 different genes. It's not that those genes aren't important. I think SHANK3 is the most important, but we certainly can't ignore those other genes and how they may affect the features and the development of your particular child. This critical region idea is at where Katie showed that little graph with the bar at the bottom, and that critical region was chosen with SHANK3 in it. But again, just because your child doesn't have a gene, it doesn't have SHANK3 involved, that doesn't mean they don't have Phelan-McDermid syndrome. These are just numbers of cases, and you can see how these are scattered out. This isn't as fancy as Katie's graph. I may have one like that in here below, but you can see they're all over the place, and the average size is going to be 4 to 5 megabases, and then people will fall either in that area or more or less. And here's that same kind of graph Katie was showing, where you can see that this region right here in this yellow and red area contains SHANK3. Now we know we've included people whose deletion may start up here and then just be this big. So we're still learning how to define Phelan-McDermid syndrome. I wanted to point this out to you because the numbers change. Katie talked about a build when you're looking at a microarray, and those numbers change depending on which build you look at, and which build was used to interpret your child's microarray is based on when they had their microarray time-wise. So as we get better and better at interpreting microarrays, the build changes, and those numbers for where a specific gene is will change a little bit. And depending on which gene or chromosome it is, it may change significantly. So when you read a report, you always have to say, look at the build that report was done in, and then there are ways using a genome browser to transfer that or translate that into the most current build to get a better idea about exactly what that means now. So it can get confusing. So as far as diagnosis, this age is decreased now, hopefully, but some of you got a diagnosis. I know some of the families I talked to today, their diagnosis came at 4 years. And that was after watching their child. I'll say moms know more about their children than anybody else. We dads sometimes are kind of out to lunch, but the mom knows, and she may know at 6 to 12 months that something's just not quite right here. Then you're going through the process of convincing the pediatrician that something's not quite right here. Pediatricians, because of who we are, we don't like to give bad news. That's why we went into pediatrics. Because we like to see kids come in and we do their well child checkup and they're doing well developmentally and they're growing well, and we can say, man, everything is hunky-dory. That's why those people went into pediatrics. So dealing with sometimes that things are not hunky-dory is a little bit outside of many pediatricians' comfort zone. So it can take a little while to convince them, because the pediatrician's going to say, well, there's a lot of variation in development. How many people heard that? There's a lot of variation in development. Let's give him another or her another 6 months and see how it goes. And then you come back and at a year of age and they say, well, you know, there's still a lot of variation in development. So let's go another 6 months and see what happens. And then when you get back at 2 years of age, you're saying, I'm not leaving this office till you do some kind of testing. And again, it has to do with who goes into pediatrics. I really believe that. Some of the other presenting symptoms may be absence of speech, developing seizures, developmental delay, and the physical features. But again, I don't expect anybody to pick up on the physical features of Phelan-McDermid syndrome and say, oh, your child has this. Katie mentioned other diagnoses that have been given to children. This doesn't happen as much now because we have microarrays that pinpoint that diagnosis for us. But we certainly know from in the past that a lot of the kids who are older now were given an incorrect diagnosis based on the best knowledge that we had that time, or sometimes just because we didn't know any better. And then a specific diagnosis of Phelan-McDermid syndrome was found. And so these are some of those diagnoses that have popped up in there. Ectodermal dysplasia means skin and nail problems. So you could see how that one would come in there with the abnormal toenails. All of these other syndromes are associated with hypotonia, which is very common. That is not a specific feature at all. And other issues that might occur. So it is not, like I said, an easy diagnosis to make clinically. It is certainly an easy diagnosis to make from a genetic laboratory standpoint, though. And I mentioned these major features. We're not going to go through all of these again, but I think to keep those in mind, I think you will appreciate this one, that when the milestones occur, so major milestones are delayed. These are the average times. These are the ranges. Rolling over is a 4-month skill for the typical child. Crawling is somewhere between 8 to 12 months. And walking, usually the cutoff we use in pediatrics is you need to be walking by 15 to 16 months. That is what we consider typical development, okay? Obviously, these things stack up on top of each other, and you get more and more developmental issues because as you grow, we ask you to do more and more complicated things as you develop, talking being the most complicated thing that we do. The good news is, though, that most of the kids with Phelan-McDermid syndrome are going to walk. Now, the bad news is when they start doing that, most of them don't just walk, they run. And they're fast. And my daughter babysat at one of the meetings we had in Greenville, and she came home every night and she said, oh my gosh, I am worn out. That little girl never stopped moving. I couldn't keep up with her. As far as the severity of development, and this is a little bit old, but I think these numbers in general are pretty good. You can see moderate developmental delay here. You can see severe here and profound here. Those numbers hopefully will change more and more advantages with therapies and things like that, and we have a better outcome. Autism, again, difficult thing to get our hands on, and if it were easy, we'd have the holy grail of autism now, but we don't. The facial features, and again, I think these closer views can give you an idea about the fullness, a little bit of the cheeks here, the hypotonia, less expression in the face, droopiness of the eyelids here. So those are the types of things we're looking for. But again, we see those in many different genetic syndromes. We talked about the feet and the hands and the dysplastic toenails. As some of the individuals get old, lymphedema, true lymphedema, or fluid leaking out of the cells into the surrounding tissues gets to be a problem. And if that's the case, we need to make sure that there's nothing that we can treat specifically, but most of the time there's not, and you have to go to symptomatic treatments like elevation of the edematous part of the body, usually the legs, because when we stand up, that causes more osmotic pressure in our extremities, and what happens is then we get more leakage of fluid into the tissues. There are certainly pressurized stockings you can wear. There are some individuals who have required automated pressure stockings where this thing has a pump in it, and it pumps gradually up the leg, and it actually massages, you can think of automatically, the fluid up from the ankle toward the groin area, and by doing that allows that to get back into the circulation and get out of the extremity. And this is I think the hardest part is that your child may have speech and then lose speech. And I think it gets back to that Shank 3 and the synaptic dysfunction that occurs over time. And here you see roughly 50-50 absent speech versus severe speech delay. And then what happens out of those folks who had speech, roughly 60% kept their speech and 40% lose their speech. And then if you take that 43% who are in here that lost their speech, most of them permanently lost that speech. I think it is critically important, again, to use augmentative communication, even when your child has speech, because that's your best opportunity to allow them to continue to communicate. Okay? Take advantage of that speech when you have it, because there's no guarantee that you're always going to have it. Who should be tested? And that was a question I think you asked about, well, why wouldn't they test my child? We could look and ask, well, shouldn't you test everybody? But the insurance company won't let you test everybody, I promise you that. So I think if they exhibit stereotypical repetitive behaviors, including that chewing, teeth grinding, tongue thrusting, that's a group to study who also has developmental delay. Autism, that with developmental delay, I think is someone to consider studying. And we typically would test children who have severe hypotonia or absent speech. Many of those kids will be tested in our office. We're not testing specifically for Phelan-McDermid syndrome. We're testing kind of a broad generalized test to look for any cause for those issues. And oh, by the way, we found out that your child has Phelan-McDermid syndrome, because when they're little, they may not have very many of those typical physical features that may guide us toward that diagnosis. Sometimes, though, there's a child who will walk in, and the genetic counselor and I will say, boy, this person looks like they have Phelan-McDermid syndrome. So, can just depend. I mentioned seizures. The other reason to have a baseline MRI is arachnoid cysts. Most of the times, those are benign lesions, meaning they're not going to cause a problem pressure-wise. But if you have a baseline MRI, if your child starts having pain of unknown etiology, gets irritable, and we're trying to figure out why did they have their pain, if that arachnoid cyst is the same size it was 3 years ago, then we can feel more assured that that's not where the pain's coming from. So then we have to worry about, could they be having urinary tract infections? Could they be having gastrointestinal reflux is a big one, and having, for lack of a better term, heartburn or severe discomfort from that? There's steps we can go through to try to figure out why your child's behavior may be changing if it appears to be pain. As part of that regression, though, sometimes behaviors change and your child could develop schizophrenic-like behavior, depression, things like that. Those can be treated, but we just need to know what we're treating before we try anything. And this is just an arachnoid cyst here. I mentioned the gastrointestinal problems. I think this is the number to focus on right here, is anybody who has hypotonia has a significantly increased risk for gastroesophageal reflux too. So that needs to be addressed. If your child seems to have problems with pain, if you let them lie down after they've eaten and they can't sleep, that may be it. If your child has persistent coughing or wheezing, this may be playing a part in that. So it's fairly easy to investigate. So I think that's worth doing. And I mentioned the renal ultrasound. Size matters, and those genes that are in that area matter. We just don't know how much they matter now. The other thing to remember is if a condition is autosomal recessive and you've knocked out one copy, we've deleted a copy, we may be unmasking changes in genes that are in that area that's deleted on the other chromosome that would not manifest at all if your child did not have that deletion in Phelan-McDermid syndrome. So again, we need to consider those possibilities and what they may mean for your child's development and things like that. This was an earlier study we did, and this wasn't based on molecular genetics per se. This was cytogenetics with some microarray in there, but looking at, so if the size of the deletion is smaller, what does it mean? Now remember that chromosomes are numbered from the centromere out. So the bigger this number, the smaller the deletion, right? Okay? Because we're going out that way. So this deletion is bigger than this one, on down the line. So what you see here is these different behaviors or problems. So walking occurred later in these children who had a larger deletion, and you can see on down the list. Interestingly, the children who had a smaller deletion had a higher risk of autism, and that's because it's difficult to accurately diagnose autism in someone who has very severe developmental delay. So to be able to say, yes, this child has autism is when they have an IQ of 30 or 40 is going to be more difficult than saying a child with an IQ of 60 has autism, just the way the tests are done. If you look at the toenails, again, you can see the bigger the deletion, the more likely you are to have some of these problems, and it goes down there. And size matters, but it's not everything. So I will leave it at that, and I'll be glad to take any questions. Or I'll make Katie answer them.
So this question is about different clinical trials and different testing of different things. It's pretty clear that the symptoms and the cases are so wildly different. How are you compensating for that when you're doing testing? Because say you test, 50 people and something has positive reactions over a small amount of them, but then that everything's so different. How can we tell if something's really making a positive impact or inconclusive when it's just so wildly different?
And that's the difficulty in research in general, is you've got to have, when you apply for a grant, let's say from the NIH, you've got to have definite markers, endpoints you can use to determine the success of your trial with that particular treatment, whether it be medication or speech therapy or whatever. And that is always difficult to quantitate, but that's what's demanded of you to get funding and to get more funding to continue your study. Some people, if we had, I know up at Mount Sinai, they've used a device to measure vocalization and whether this treatment increased vocalization. Well, is that a measurement of functional development? We don't know that, but you've got to find something that you can measure. If you can measure a chemical in the body, then that may be something you could use. But you got to remember the R and the S in research mean real slow. And that I'm not trying to be funny, but you just have to be prepared for that. And I don't know where, I don't see Chris in here. One of the dads is a drug developer, and he will tell you that their drug company may spend millions and millions of dollars and 10 to 15 years to develop a drug for a very specific disorder, much less something that is harder to measure than development or autism or things like that. So it's difficult. I don't have an answer for that because it's difficult. And you got to find those things. If you want to get the funding for your research, you've got to find those things. You've got to have, and then remember you're going to have to go through a cellular model, then you're going to have to go through an animal model, and you're going to have to show all kinds of proof that there's a positive response in those models prior to being able to test a child. The other thing is it's going to have to, the drug then first has to be given to non-affected individuals as a safety trial many times. And then, if it's safe, you can start going. But typically, we start testing drugs in adults, not children, because we protect vulnerable individuals. So children are, especially children with developmental delays, are the most vulnerable individuals we have in our society. So we're always going, again, the process stepping down just takes a long, long time to do.
Is there any plans in the near future to start using CRISPR gene therapy as a means to possibly replace either the SHANK3 or other genes along the deletion?
You opened up a can of worms there. For those of you who don't know, there are ways now to, in animal models and cellular models, to edit genes so you can clip things in and out and try to replace things that are missing is going to be the easiest ones to attack first. I don't know of anything specific for Phelan-McDermid syndrome, but at the research symposium, I think that's a good question to ask to those folks. And they may be doing that in an animal model. What? Right, used in agriculture in the U.S. to put in the genes you want, or that are going to fight, that are going to be more resistant to insects or viral diseases or increased yield, or that's all those GMOs, genetically modified organisms. There are ways to do that, and that's going to be a much simpler way to genetically modify organisms. Now, whether we're one of those organisms that gets modified, who knows? We'll see.
I just wanted to underscore your point about the pain perception. Our daughter is 31 and was actually just diagnosed about 6 months ago.
Okay, she just upped our average age there.
And really, it was mostly done because her older sister wants to have a child, and we wanted to find out if there was any. And she, clearly the initial presenting stuff was kind of all there, but she really carried just diagnosis of intellectual disability, and then she developed bipolar disorder. But she speaks very well, and she moves well, and she functions pretty well, except for the mental illness piece. But a couple of years ago, she had what we thought was a bad flu. And we kind of treated it as a bad flu, and it turned out that she had really severe bilateral kidney infections. She had no pain when she peed. She had no pain when you punched her back, all of those typical things. She got really ill, and, it was just smart that, my husband and I are both docs, so we said, oh, she's got the flu. There's nothing focal here. Her roommate had the flu.
Don't treat your own child.
Tell me about it. I mean, but she really seemed. So we took her in, and someone said, "Well, why don't we just do a urine analysis and then we're off, to whatever." But it's just really important
I'm curious. Did her behavior become worse when she had her kidney infection?
She was she's always been kind of a little bit quieter and better, in that mold of autism when the kids have the fevers and they seem to do better, which is really such a fascinating issue. She really didn't have major behavior. She was a pretty mellow kid generally, except when the bipolar thing kicks in. So, but yes, she was more.
The reason I ask that is because at my church, people come up and ask me medical questions, and I try to tell them I'm a geneticist. I certainly don't know everything about medicine, but I think it is important to note that sometimes people who have mild dementia or other illnesses, when they have a urinary tract infection, it will make them act a little bit crazy.
Oh, really? No, yes, she did.
Yeah,
but
yeah.
I was really talking to the fact that a lot of my friends who have kids with autism say that when their kids have high fevers, they seem to be better. So, that's that other piece.
Yeah.
But you really have to be careful.
Okay. Anybody else? Okay.
So I have a question about cooling and sensitivity to heat. And our child might also affect your numbers because he's 37 and was only diagnosed at 29.
Boy, my slide's getting worse and worse.
Okay. Sorry about that. All right, so my question has to do with heating, cooling and sensitivity to heat. Christopher was always sensitive to the heat, but was able to handle it much better than he has in more recent years. At this point, especially on days like this in New York, walking from the front door to the car, he's melting, and you can see him tilting to the left. Right. You had made reference that the thought regarding sensitivity to pain was more driven at the brain level rather than the skin level. What is the thought regarding sensitivity to heat and the ability
I think that's a general autonomic dysfunction, which is what controls your heart rate, your ability to perspire. It's the things that your body does for you that you don't have to think about, okay? So I think underlying all of that, there is an autonomic nervous system dysfunction that leads to some of that, okay? Is this the last one? Are
wow.
you cutting me off here? I see. And we will have, I think we've got a question and answer session on Friday or something like that, too. Is it Saturday? I couldn't remember when. Okay.
Oh, yes, sorry. This is, now that it has to be an amazing question now, I think. So are there any other disorders that have regression? Yes, ma'am. Are there any other orders that have like language regression or other kinds of developmental regression that would give us some clue as to why there's such variation in Bailey-McDermott?
Well, there's certainly others that have regression, and we can look no further than I don't call autism really a diagnosis. That's a description of your neurobehavior to me. Again, my example of the apples, and we just don't know what causes autism, but that is one of the typical features that is seen in children and how they present with autism, is they'll be developing typically till 18 months to 24 months of age and then lose their speech. And sometimes it is like this. The mothers will come in and say, my child was talking in sentences and now won't say a thing. Rett syndrome has a regression too. Typically, in Rett syndrome, that regression occurs somewhat later because they plateau and then they start going down and losing skills. But yeah, there are a lot of neuro disorders that can do that. Yeah, there. I think Dr. Bernstein is doing a session on regression, so you may want to come to that. All right.